Alright, so this is going to be a video tutorial over how to do a low vision refraction. We have with us here our patient, we'll call him Mr. Smith, and we're going to conduct a low vision refraction on him. So as part of the low vision refraction, we are giving out the retinoscopy findings, we're giving the students the retinoscopy findings, and we're also giving the students their visual acuities. And so from those visual acuities, the clinician should be able to determine their just noticeable difference, which are the lenses that we're going to use. We're going to show the patient a minimum amount of change in order to make sure that they're able to see the change on the chart. And what I mean by that is that patients with low vision are often not able to see a very small change of a quarter diopter as a patient with normal sight would be able to see. So what we have to do is we have to use a very simple formula where we take their Snellen acuity, the denominator, divided by 100. So say for instance that our patient's Snellen acuity is 20/100. We would take the 100, we would divide it by 100, and that would give us a just noticeable difference of 1 diopter. And what this means is that every time we show the patient a change, a spherical change, we need to change that by 1 diopter at minimum. There are instances where, in a more advanced refraction, the patient may not be able to appreciate 1 diopter of change. Every patient is different. And so in these instances, we may need to go up a little bit in our diopter. So the just noticeable difference is considered a rule of thumb. Basically it's just an easy starting point, and you can change it appropriately if you feel like the patient is doing much better or is doing much worse. You may need to adjust that diopter amount. All right, so what we're going to do is we're just going to imagine that we've already got visual acuities, we've already got retinoscopy findings, and so we're going to start by putting on the trial frame. And so I'll go ahead and have you take your glasses off for me, if you could please. We already had the retinoscopy findings, and just like in the proficiency, those are given to us, and so I have placed them in the trial frame. Now, one of the things that you need to note whenever you're conducting a trial frame proficiency is the placement of the lenses. And so for the proficiency, you should place them correctly and in the correct wells. So for instance, the sphere should go in the back well. The cylinders should go in the front well. And just kind of a little tip, and I've mentioned this in class before, is I recommend placing the handle against the stop on the front of the trial frame here, just so that it's easy to change out. And if you have to change your cylindrical lenses or something like that, it's very easy to swap them out without having to modify where the axis is every single time. So as part of the proficiency, we're also going to ask the students to place the trial frame on the patient's face correctly and then make adjustments. And so as part of that, we want the clinicians to be careful placing the frame on the patient's face. We don't want to jab somebody, we don't want to hurt our patients or anything like that. So I extend the temples all the way out, and then I pull them apart just like so, and then I'm going to bring them over here and place them on the patient's face. All right, Drew, just let me know if that's getting too tight. Is that okay right there? Okay. The next thing that we need to do is we need to adjust the trial frame. And so in the instance here, it's running a little bit low, and so I'm going to bring it up just a little bit. And then I'm going to check my panoscopic tilt and see how we look from the side. And we're a little flat, so I'm going to adjust this here and adjust this over here. The panoscopic tilt, when set correctly, it will also better align the frame on the patient's face. All right, so we've got the frame on the patient's face, and we've also checked the PD, making sure that his eye is centered there, and we're centered, in the B dimension as best as we possibly can. Now, we're going to start our trial frame refraction, and so the first thing that we're going to do is select our flipper. Since his just noticeable difference, as we've already calculated, was 1 diopter, we're going to grab a 1 diopter flipper, and so it's going to have a +1 and a -1 in the flipper itself. The next thing that you need to do is you need to select the appropriate target for your patient. So for instance, patient's visual acuities were 20/100. For our initial sphere, we need to select 2 lines above best visual acuity. And so let me check that real quick. This is the 2100 line. So Drew, I'm going to have you looking right up here, okay? This is ECRDH line. Are you able to see that?
Yeah.
Okay. So now I will have the patient continue to look at those. He doesn't have to look at a specific optotype. And I'll have you try or look up there and tell me which one do you feel like is better. 1 or 2?
2.
2? Okay. The other thing that a clinician may say is with the lens or without the lens. That's fine as well. So I'll show you that one here. All right. And how about with the lens or without the lens? With the lens. Okay. So the patient wanted more minus, and so I'm going to very gently pull this lens out while grasping the trial frame so that it doesn't pull or tweak on or torque on his face. So let me grab, this was a 350, I'm going to grab the 450 here. Same thing, grasp the frame here and slide the lens in, being careful not to twist the frame on the patient's face. All right, so let's do it again. I'm still looking at the same letters up there, okay? Now let's go with the lens or without the lens.
About the same.
About the same, okay? Now, sometimes what I do in the case of a real patient is I'll just quickly check on the plus side again. And I'll say with the lens or without the lens.
About the same too.
About the same, okay. So in these cases, the patient wanted more minus initially, and now is kind of giving me mixed signals that maybe plus might be, helpful or something like that. I'm going to remember that because his true refraction, he started off at a minus 350. Now we've got a minus 450 sphere in there. The true refraction may be somewhere in between. But for now, we're going to move on with the refraction, and we'll come back to that later. So that's the end of initial sphere there. I'm going to put my one diopter flipper back here in the trial frame, or in this rack. And now I'm going to grab my JCC lenses. Just like on the proficiency, you will have this rack here, or you will have your own JCCs that are going to be marked appropriately for the patient's visual acuity. Patient was 2100, so I'm going to grab the plus or minus 75 JCC flipper. Now we need to select a specific optotype. So we're going to stay at the same line of acuity. We're not going to change our optotype or our line or anything like that. But now what I'm going to have the patient do is look at a round or circular optotype. And so Drew, I want you to look at that C that's right next to the Z. Are you able to see that?
Yeah.
Okay. Now as part of cylindrical testing, you're going to check power, axis, power. And so the first thing that we want to check is power, and then we'll refine axis, and then we'll come back and recheck power one more time. So I'm going to align the lines on the JCC up with the lines on the cylinder power that's in the lens. All right, looking at that C, better 1 or 2?
2.
2, all right, so the patient is wanting more plus in this case. He's got a minus 2 in there, and so I'm going to remove that, and instead I'm going to grab a minus 125. Because the patient, we're using a plus or minus 75 JCC lens, a minus 2 is in there, he wanted on the plus side, and so I'm going to select a minus 125 in this case. All right. And looking up there, still at that C, better 1 or 2?
1.
1 was better here?
Mm-hmm.
Okay. Now the patient accepted more plus there, and so now I'm going to drop down from a 125 to a minus 50. Okay, and just repeat until the patient notices either neutrality or they want to go back up to more minus. All right, better 1 or 2?
1.
1 was better here?
Mm-hmm.
Okay. So now we've reached kind of an interesting point because the patient is wanting to effectively kick out all of the cylinder. So this may be true. The patient really may not need any cylinder at all, or the axis may be a little bit off. And so since we still have some cylindrical power in here, what I'm going to do is just quickly check the axis and make sure that we don't need to make some change. that will ultimately increase his cylindrical power. So this may be a little bit different from the way the trial frame proficiency may go, but it is a realistic thing that occurs all the time with our low vision patients. All right, so still looking at that C for me, okay? I want you to tell me which one makes that C appear more real or more circular. Here's 1, and here's 2.
1.
1 was a little better, okay. Same thing, here's 1, here's 2. 1, okay. So all I'm doing is chasing the red. For instance, I'm putting the cylinder axis here, and if I say this is 1 and this is 2, he selected 1, so then I'm going to turn the cylinder axis just like you do with the JCC lens in the phoropter. And I'm moving it about 15 degrees each time that I'm changing the axis. 1 or 2, or no difference. Here's 1.
Yeah, they're really similar.
There's 2. Okay.
Yeah.
So the patient has noticed neutrality at around 70 degrees. So I know that on the lesser degree side, so say less than 70, we know we don't want to be over there. He's happy at 70. We've already covered from about 40 to 70. But part of what we need to do is check on the other side, because we want the patient to reject a higher degree, for instance, closer to 90, so that we know that we're right in the middle. We know we're about 70 degrees, give or take. So I'm at 70. I'm going to rotate up to about 85, and I'm going to check again and see if he takes me back to 70. And here's 1 and 2. 2. All right, so this time he's taking me back, and so now I've found, he doesn't want to be on either side, and we found neutrality at 70 degrees, so that's where I'm going to put the axis back. All right, now we're going to check power again, and remember earlier he had kicked out some of this power, almost to the point of no cylinder. So we're just going to reevaluate that now that we found maybe a slightly different axis. Here's 1, and here's 2.
Yeah, they're about the same.
About the same there? Okay. So he noted neutrality. If I take the lens out completely, then effectively I'm rotating around plano with my cylindrical lens. So I don't want to remove the -0.5, but instead what I want to do is go back up to -125 and see if he takes me back to -50. Because in that case, we can't kind of go on the floor, but we can effectively bracket up higher. So let me remove this lens here. Grab the 125 again. And again, I push the handle of the lens all the way to that stop. It makes it real easy to find. Okay, so we're back up to -125, and now we're checking the power again. Looking at that C, here's 1, here's 2. 2. All right, so he's taking me back down to the plus. So we're somewhere around a -50. The fact that he was finding a spot for cylindrical or for a cylindrical axis indicates that he does have some amount of astigmatism there, and we're somewhere around a half a diopter, give or take. All right, so at this point we have checked our initial sphere, we have checked our cylinder by doing power axis power, and now we're on to final sphere. So this is the point where things get a little tricky, okay? Because what we're wanting to do is we're wanting to avoid bias by showing the patient with the lens and without a lens. There are some patients who find that the vision is always clear with the lens, and there's some patients who feel like the vision is always clear without the lens. And so we want to avoid that bias. But the only way that we can do that in the trial frame refraction here, is to have the J and D. So now we're going to, instead of having a +1 or -1 and only showing in one lens at a time, I'm going to grab the plus or minus half flipper. The other thing I'm going to do is I need to bracket. So we're thinking that we're somewhere around -4 to -450. So what I'm going to do is I'm going to remove the 450, and instead I'm going to put in a -4. With the plus or minus flipper, what I'm going to do then with a plus or minus 4 lens in the back well there. If I show him a plus a half, then I'm showing him minus 350. If I show him a minus a half, then I'm showing him minus 450. And so in this way, we're able to bracket a whole diopter just like before. Now, as part of the final sphere testing, we need to change our patient's fixation. And so now, Drew, I want you to look at the line that says NVSOK. Are you able to see that?
Yes.
You can look at any letter that you like. You don't need to select a specific optotype for the final sphere, but you do need to have them one line above best entering acuity, okay? So now with this one, we're not going with or without. We're going to keep the lens in front of the patient all the time because we truly don't care about this minus 4 that's here. What we want the patient to do is look through the 2 lenses that we're showing them through the flipper. All right, so now I'll have you look up there and tell me which is clear or which makes the letters more plain, 1 or 2?
1.
1, okay? So we've got a minus 4, and he selected the minus 4.5, or minus the half. So he wants to go back up to a minus 450. So we bracketed on the low side. Now we need to bracket on the high side. And so what we're going to do is grab a minus 5. Let me put this in place here. Again, paying special attention to holding the frame, making sure that the patient is comfortable. So now I've still got the minus half, or plus or minus half flippers, and I'm going to show him, if I show him a minus a half, I'm showing him minus 550. If I show him plus a half, I'm showing him minus 450. Because remember, we already bracketed. I was showing him 350 versus 450, and he wanted the 450. Now we're going to show him 550 versus 450, and we're going to see where he takes us. Okay, same line, and I'm looking for clarity, okay? Not just darker or getting smaller, okay? Here is choice 1 and choice 2.
1.
1 is clear, okay. So now he's taking me back down to a 450. So he wanted the plus a half, so now I'm going to put the 450 back in front of him. If I can find it. All right, so 450 is back in front of him. As part of a final step, one thing that sometimes I'll check is, with the plus or minus half one more time. From the standpoint of the proficiency, at this point you are done because you found that the patient wants the 450, you checked on the low side at minus 350, you checked on the minus side at 550, and the patient doesn't want either of those options. You've bracketed, and you know that they're right there in the middle, somewhere around minus 4.5 diopters. So for all intents and purposes in the trial frame refraction, you're done. But what I do with the patient oftentimes is I just want to check and see around the 450. So technically we're checking to see if the patient wants a minus 4 versus a minus 5. But what may often happen is if you're right on the money as far as your refraction is concerned, is that the patient will note that neither lens is better than the other. They effectively will note neutrality with the 2 lenses. So still looking at the same line, NVSOK, and which choice looks clear here? 1 or 2 are about the same. Here's 1, here's 2.
About the same.
About the same, okay. And so in that instance, we're all the way finished, except for the last part where we're going to check VAs. Now, Drew, I want you to look up there and read, or go ahead and start at that NVSOK and read as low as you can for me.
NVSOK, DRZKO, SNHCV, CRVSZ.
And I think that's going to be good
All
enough
right.
for the purposes of the proficiency. And so the final step for the proficiency is to look and see what the patient's VAs are, and in that way we can determine Kestenbaum's rule, or the approximate add that the patient will need. So let me look at the Snellen acuity real quick. Since the chart's at 4 meters, we can look over here at the Snellen acuity, and the acuity is 20/63. And so at this instance, Kestenbaum's rule, all we have to do is invert the fraction, and so it's 63 divided by 20, which is somewhere around 3 diopters. Now if we were going to double that, we would give the patient 6 diopters for comfort while reading. And I think that's it.